Okay, the next portion of the PowerPoint that I want to go over are clinical manifestations that you're going to see in a patient who suffers from heart failure. We're going to talk about the different types of heart failure and how the manifestations differ from the different types of heart failure. So this next set of PowerPoint voiceover slides are going to be focusing on that. Then I'll do a separate one that will talk more about collaborative care of the patient with chronic heart failure. And then nursing management, we're going to talk about. We're going to skip in this chapter, we're going to skip over cardiac transplantation, although I think it's valuable to note that depending on the severity of the heart failure and the level of heart failure, the chapter talks about the different levels, levels 1 through 5. Depending on where they're at, they could be eligible for a potential heart transplant. We're not going to go into any of that transplant stuff. We are going to talk about clinical manifestations. We're going to talk about diagnostic studies, and then in another PowerPoint, collaborative care and nursing management. Okay, and talking about different types of heart failure, the first we're going to focus on is left-sided heart failure. This is the most common type of heart failure that you're going to see. This means that there's dysfunction in the left ventricle. So on the previous set of PowerPoints that we talked about the flow of blood and the function of each of the different ventricles and compartments of the heart. So that left ventricle is the largest part of the heart. That left ventricle is responsible for pushing the blood to all the extremities, all the capillaries, all the vital organs. So it has a really important job. So that one, when you think of the malfunction of the pump or the wear and tear on the pump, is oftentimes the first one to dysfunction or to stop working properly, usually as a result of a MI that's happened on the left side of the heart. That muscle has become ischemic or has had some kind of trauma. Hypertension, that continuous work of the left ventricle trying to push blood with the resistance of the afterload of the heart and that wear and tear from that. Coronary artery disease, and then the results of the work of the heart and that cardiomyopathy. So basically that ventricle stops working or functioning as it should, so backup of blood starts to happen. So if you think of the job of that ventricle to push blood everywhere in the body and it's not able to do that, where it would back up to. So you have to kind of road map the heart and go backwards. So from the left ventricle going back up to the left atrium and then going up through the pulmonary veins. Because remember, I'll just review it one more time. The venous blood comes through the right atrium to the right ventricle, through the pulmonary arteries. Gas exchange happens within the lungs and in the alveoli, and then the blood comes through the pulmonary veins into the left atrium to the left ventricle and out. So the backup starts to happen there in the atrium, the pulmonary veins, and then pulmonary congestion develops. So this is pretty common. If a patient is suffering from left-sided heart failure, your assessment findings will be consistent of crackles in the patient's lungs and oxygenation issues. Now, if it's hypertension and other things, that resistance and that lack of proper perfusion, they can have some peripheral edema, but that's usually more related to the right-sided heart failure, which we'll talk about next. And this table here you can find in your book. It's figure 35-2. It goes into the pathophysiology and the flow or the steps in heart failure related to the left side. So this is more of a review from what we've already talked about. We didn't get into a lot of detail on some of those, the angiotensin and angiotensin 2, but we did talk about the ADH and we did talk about that. So just kind of be familiar with it. This is more just to reinforce anything that maybe you have read about or have heard me talk about that you're not understanding. Just take a look at this table to see if it can help reinforce some of that. Okay, so we're going to talk a little bit, that when we refer to heart failure, there's two main types. We talked a little bit about the systolic, diastolic, but really what we're talking about when we talk about heart failure is either right-sided or left-sided. Right-sided heart failure is often a result from left-sided. So initially the patient has left-sided heart failure that progresses to right-sided heart failure. Right-sided heart failure can also be related to injury to the right ventricle or cor pulmonale, you'll hear it referred to as well. Patients that have any kind of pulmonary artery hypertension or resistance in that pulmonary artery can in turn develop right-sided heart failure. So if you again think about the flow of blood, that right ventricle is unable to properly contract to get the blood into the lungs for oxygenation. So the backup starts happening through the right atrium and then back through the venous system. Um, when you're looking at assessment manifestations or assessing a patient that has right-sided heart failure, you will commonly see JVD in these patients, or jugular venous distension. These patients also, with the backup in their circulatory system, it affects their liver and their spleen, so they can also suffer from some ascites and issues related to that. Vascular congestion of the GI tract and peripheral edema. So more common, you'll see these patients. These patients are usually can be severely hypoxic because they're not, because of the dysfunction of the right ventricle. There's not enough blood perfusing through the lungs to get oxygenated. So these patients are going to have extremity edema. They're going to have the abdomen ascites issues. They're going to have the JVD. So when you go to do your assessment of these patients, maybe you're not sure if the patient's having right-sided or left-sided heart failure. Maybe it's not clearly stated on the patient's medical records. Based on your assessment, you can get a good understanding of what kind of level of heart failure they're at, or where exactly it's affected, whether it's left-sided and they're having pulmonary congestion, or it's right-sided and they're having extremity congestion or issues with perfusion in their extremities as far as edema goes. There is a term called acute decompensated heart failure, or ADHF. This is truly an acute episode. You guys will learn more about this in block 4. So the chapter does cover it, but I'm not going to cover it in great detail. Just know that this is often life-threatening. So it's an acute episode of severe pulmonary edema. You'll hear the term pink frothy sputum, and that can be life-threatening. So that's to the point circulation's been interrupted, the ventricles aren't perfusing properly, and the lungs are filling up, the capillaries are filling up, the alveoli are filling up with fluids. So we're having decreased oxygenation, the patient's really struggling. They're having acid-base balances throughout their system due to lack of proper oxygenation and perfusion. Like I said, we're not going to go into this. This is all acute. As far as the tests, the diagnostics, and the interventions, they are all a little bit above our learning level for purposes of block 1. So I wanted to leave this slide here just to address it, but to just understand that this isn't expected for testing purposes. This is something you guys will elaborate on and go into more in further semesters. All right, so this figure here, 35-3, this is a good visual. It talks about the normal relationship that the capillaries, the lymphatic system, and the alveoli play. And you can see A is your normal relationship or normal healthy alveoli, and then it goes all the way to D, where it's a failed working relationship and system. So if you want to read a little bit more about that to have an understanding there, that would kind of help clear the air. So like I said, A is your normal healthy relationship, and then B, C, and D progressively worsen.
Normal cardiopulmonary anatomy is animated, and the patient is placed on a cardiac monitor that shows normal sinus rhythm and normal vital signs. The chest radiograph is also normal. When the systemic circulation is overloaded with fluid or is under high pressure, the heart may dilate in an attempt to pump more forcibly. Pressure building within the pulmonary circulation can cause capillary fluid to leak gradually into air spaces, resulting in pulmonary edema, which is often a pink, frothy liquid. The superimposed chest radiograph shows the cardiomegaly and the pulmonary edema typical of congestive heart failure. Because the edema fluid may now be collected within the air spaces of the lung, a decline in the oxygen saturation of the blood is expected. The pulse oximeter reading drops accordingly. Physical examination of the lungs may reveal inspiratory crackles or rales, which are caused by fluid in the small air spaces. Examination of the heart may demonstrate an extra heart sound or gallop, indicative of heart failure. Examination of the neck veins may lead to a finding of jugular venous distension, or JVD. This reflects the increased pressure within the right side of the heart, into which the jugular vein must empty. Supplemental oxygen should be administered to the patient, whose air spaces now contain some edema fluid. The oxygen-enriched air will supply additional oxygen to the open airways of the lung and partially offset the effect of the fluid. This may result in an improvement in the oxygen saturation of the blood, as reflected in the rise in the pulse oximeter. The next line of therapy is to reduce the afterload, or the pressure against which the heart must pump. Nitroglycerin administered sublingually, under the tongue, is rapidly absorbed and effective in decreasing this pressure on the heart. In response, the blood pressure decreases, as seen on the monitor. A second medication frequently used to treat congestion is furosemide, a powerful diuretic that can be administered intravenously. The initial dose for an average-sized adult ranges from 40 milligrams to 80 milligrams. Furosemide acts on the kidneys to produce urine, decreasing the intravascular volume. As the intravascular pressure and volume are relieved, pulmonary edema gradually resolves, vital signs normalize, and the patient improves clinically.
This slide actually should represent the video that I put in Canvas for you guys, and I tagged it and I said, watch this video. You guys will have to give me some feedback via email to let me know if you're able to view the video or not. It's a really good video that shows what's happening intravascularly. If we're unable to view it, I'll show it at the beginning of class. I just want to have the heads up so I know. But I'd like to show it so that you guys, if you're unable to see it through Canvas, you can see a clear picture of what's happening systemically, what's happening in the heart, what's happening with the lungs, and what happens when treatment is initiated for heart failure. When we talk about clinical manifestations of chronic heart failure, these are common things that you would expect to find, common assessment findings you would expect in patient suffering from heart failure. So based on what you've learned about and what you've read about and what you've listened to me talk about thus far, be thinking to yourself, what are some expected clinical manifestations? If I have a patient whose pump is broken or not working properly, how would I expect them to present? What would I expect to see? So I hope that fatigue or just an overall just being tired should be obvious. Difficulty breathing or dyspnea or orthopnea. I hope everyone knows orthopnea. Paroxysmal nocturnal dyspnea. All those areas of difficulty breathing, whether they're with exercise, at rest, while laying down, whatever it is that they are having difficulty catching breath or having difficulty breathing. A persistent dry cough, unrelieved with position changes or over-the-counter cough suppressants, and tachycardia, if you think of the work of the heart and what it's trying to do. Also, these manifestations depend on the patient's age and what the underlying type of heart failure is and the extent of the disease. So those may vary as well. But pretty commonly, the symptoms include fatigue, cough, dyspnea, tachycardia, edema, and some limitations in their physical activity for their ADLs. To continue on with some of those clinical manifestations, dependent edema. Again, we talked about this specifically with right heart failure. There can be some with left-sided heart failure as well, more common in right-sided heart failure, or chronic heart failure if they're both left and right. The edema may be pitting in nature. Some things that we want to be assessing for is weight changes in our patient. If the patient's there in an acute care setting, we determine a lot by weight. Um, but we want to make sure we're educating our patient about that too. So any sudden weight gain of more than 3 pounds in 2 days, it's either 3 pounds in 2 days or 5 pounds in a week. That could be an indicator that the patient's experiencing exacerbation of their heart failure. So in the notes on this slide that you probably can't see on the voiceover, but go back and look at, it says it may occur in dependent body areas, peripheral edema, liver for hepatomegaly, abdominal cavity for ascites, or in the lungs in pulmonary edema or pulmonary effusions. If the patient is in bed, the sacral or scrotal edema may develop as well. So daily weights on these patients in the acute care setting is really important. It's the best indicator for weight gained or weight lost, specifically water weight, because this is a fluid volume issue. The heart failure, the pump isn't working, and so perfusion in circulation isn't happening efficiently or effectively, which results in the backup of fluid. And if the fluid backs up for too long, it will result in weight gain. So it's really important to educate the patient about how to weigh themselves at the same time every day, wearing the same amount of clothing, to keep a record of it. Don't just memorize it, but maybe even write it down, create a log to follow, so that they're able to be aware if there's an exacerbation taking place. Making sure the patient's compliant with the regimen, which we'll get into as far as collaborative care here in a minute. But it's really important, this scale. If you think about it, 1 kilogram is equivalent to 2 pounds, which is equivalent to 1 liter. 2.2 pounds, sorry, is equivalent to 1 liter of fluid. So if they go up 3 pounds, that's almost 1.5 liters of fluid that they're retaining. So they're going to have a lot of edema. It can eventually really suffocate them in the pulmonary area. So it's really important that we keep track of it, that we educate them on it, that they know that that is the best indicator to know if they're how well they're managing their heart failure. Continuing on with the clinical manifestations of chronic heart failure, nocturia can be defined as needing to get up to urinate frequently in the night. If you think about the heart and its decreased workload at rest while the patients are sleeping and resting, more efficient perfusion could be happening at that time, causing the patient to need to get up and use the restroom more, as some of that extra fluid may be leaving the patient. And then the skin, dusky, cool, damp to the touch. Again, the lower extremities, due to the edema, could be shiny and swollen. They may not have as much hair growth, or they may have pigment changes related to the edema and related to some vascular lack of circulation or vascular issues related to the heart failure. And then the last slide that we're going to talk about on clinical manifestations of chronic heart failure is just a continuum of the previous slides. So the patient could potentially have restlessness, confusion, decreased memory. Again, if you're thinking about the work of the heart or the lack of the function of the pump, not able to properly perfuse the most important vital organ of the brain, they can have increased confusion and decreased memory, just related to lack of proper perfusion and circulation. These patients can experience chest pain or have angina, again, with the work that the heart's trying to do and its inability to do so. There may be some ischemic or some potential chest pain experience that the patient's having. Weight changes, again, we talked about the fluid retention and the potential for weight gain, but these patients can also experience anorexia and nausea related to lack of perfusion, improper function of the heart and circulatory system.